Yeah, thank you very much, sir. It's actually onerous task to talk about finance after a sumptuous lunch. In fact, as much as it is difficult for you guys to listen, it will be difficult for me to as well speak. So, very good lunch. Thanks to the department and the team here. So, where's slides? And the okay, so while we are getting the slide changer, I just was wondering when Dr. Jawahar asked me to talk on this subject, I actually thought that why is that we are going to talk about healthcare financing? We all know about it. It's been so many years, last 2-3 decades, we have always been talking about financing. And believe me, the more we talk about it, the more we dwell on it, I've realized that it's much more vast than what we actually see. It's a tip of iceberg. And incidentally, as the universe would have it or the department would have it, all my teachers have always thrown me into talking and working in the space of costing, financing. So it has actually helped me into learning about healthcare financing in a very great depth. And what I'm going to present today is what we did a research with National Institute of Public Finance and Policy on various kinds of financing models across the world. So we studied 16 countries, including some of the South Asian countries and some of the developed countries. And therefore, how do we actually see financing? Huh? 80 PPT connect nahi paribani? No, I cannot change actually. So, okay. So the narrower approach to any financing would be very simple, that where the funds come from and where it goes. So if you actually see, financing has got multiple threads going everywhere, like the electrical wiring system that we see typically in India. But if you look at broader approach, if you go in depth into it, you will realize that it is much beyond how a funding is happening and where it is going. It is into overall critical public policy. It's an instrument to influence and address the health system requirement. Next, please. So therefore, we need to understand that what happens and what is really health financing and how we should move forward. Next, please. So here what is important for us to understand, sorry for the interruption. So if you see, India in its commitment stands committed to provide universal healthcare by 2025. We are already very close to it. Our healthcare utilization has increased in terms of its infrastructure by around 50%. Now you would say by around 50% to what? That is more important to understand. We have had multiple insurance schemes that started with Rashtriya Swasthya Bima Yojana, first piloted way back in 2006-07 in Andhra Pradesh, and which now has taken multiple shapes and has gotten scaled up into Aayushman Bharat program, and every state has got a state insurance program. So if you see, but challenge is 63% of our healthcare expenditure is still out of pocket. This is a great challenge. The current expenditure on health is 1.1%. This is the public expenditure that I am talking about. The budget outlay that the current Modi government actually claimed is about 69,000 crore, inclusive of around 6,400 crore for PMJAY. This is our Union Budget 2021. India aims to increase the healthcare spending by 3% of GDP by 2022. We are already there and we are close to 3%, not really 3%. So, however, we have a shortage of services, 40 to 60% in public hospitals, from generalists to specialists respectively. Next, please. So, if you actually look at the health expenditure in India and select states, I've picked up some of the forward-looking states and larger in size states. I did not pick up small states. So, if you actually look at it, from the fiscal year 2014-15 to 16-17, we in India, if you all know, get all our national health accounts 2 years later than that in the public domain, 2 years later than what it has been actually spent, right? So, 2016 data we get it, 2016-17 data we get it in 2018-19, yeah, 19-20. And then you had COVID period. I have specifically chosen not to pick up the COVID period because that's a pandemic situation and they had different realities which in a normal situation of financing doesn't fit in. So we are talking about the usual financing mechanisms. So if you actually look at it, so we have been by and large same in most of the state except for Kerala, which went up to 4.5% in the fiscal year 2016-17. And if you look at that, per capita total health expenditure for the states at an all India average has been around 4,300 rupees, highest being that of Kerala at 8,000 rupees. So, but majority hovered around, say, 4,000 or 4,500. Next, please. But if you look at our out-of-pocket expenditure, as per the current prices, if you see, on an average, we have been same in 14-15 to 16-17, and things have not changed in up to 2018. COVID time was different. If you see, around 3,000 rupees has been the out-of-pocket expenditure, and if you see, it is around 1.6% of the overall GDP that we spend. So even if we are close to 3% of spending in healthcare, close to 60% is spent as out-of-pocket expenditure. That's the main point I want to make. Next, please. So if you look at the centered versus state funding, this is important to understand. If you see the first speaker, Dr. Jain, talked about the overall healthcare landscape, the breadth and depth of the budget outlay. But what you see here is the spending pattern. If you actually see here, you would realize that at an all India level, so the red line is all India. If you see, all the states have been by and large spending low year on year, and one was a decadal change from 1995-96 to 2000, and then year on year when I compared, the rates are actually, the spending is actually going down, excepting for Kerala, which went up high by 1.25%. But otherwise, all the state health funding are going down. They have got two implications. Either as a state, I am very efficient and I have achieved what I want, and therefore I no longer need to spend that much. That is one possibility. The other is that I am too much dependent on the center's funding to actually take care of my health requirement. These are two things that we need to keep in mind. I am posing all these questions. You are encouraged to do further research on this. Next, please. But then we need to understand that health is a state subject. Now, when we say state subject, we typically understand that public health is state subject. It's not like that. It is private health or out-of-pocket expenditure increase in a state is also a state subject. It is the responsibility of a state to understand why my people are spending so much on their health. That is only when you understand this entire scheme of things that you will actually make a difference in the catastrophic expenses. If you see a state as big as Maharashtra spent over 17% in 2004 to 2014. In a decade's time, 23.3% it increased by 17% from 2004 to 2014. So it's a huge increase in catastrophic healthcare spending, whereas the national average was close to 3%. This is something which is very important as a state, that we need to understand that how my people or my state is spending. Next, please. So therefore, as regards universalization of healthcare, what is important for us to understand is how can we achieve universalization? What should be the role of government? Should it be a provider or a purchaser? Who is a provider of a service today? You see government also providing services through its public delivery system, and you also see government as a purchaser of services for its employees and staff, whether it is CGHS or ESIC. It purchases services from private sector. So it has both roles. So what should be the role of government? It's something that needs to be understood. And what should be the optimal mix to ensure this? Next, please. So if you look at financing, it has got three clear layers. One is mobilizing funds, two is allocating funds, and three is ensuring mechanism of paying these. If you see 1970s globally, we started talking about voluntary and community-based health insurance schemes, which shifted more towards overall health financing in 80s. Then you had got the 2000 again started talking about only social funding is not possible. You should look at larger community-based funding. So there are dual challenge both developing country and developed country face. The developed countries face the challenge of increased usage, that is therefore to contain cost, and the developing countries were facing the challenge of health for all. Both had certain set of challenge, and it will be interesting to understand that India is one country because of its heterogeneity of population and the span of the landmass and the population. It has experimented in all kinds of models. So here you have got a huge ground of experience and learning which needs to be looked at. Next, please. Next, please. So therefore, when we look at financing, we need to understand that who bears the burden, how much money is available to you. We have to remember that the limited resources are always going to be a challenge for every country. How am I going to pool my risk? What are the healthcare costs? Next, please. So there are three things that any healthcare financing system should do. One is, it should be raising revenues, it should be able to pool revenues. When you talk of raising revenues, it should talk about sufficiency and sustainability. And when you're talking about pooling, it is always equitability, efficiently given, and purchasing is basically allocative and technical efficiency. What is your quality of service? Based on that, your purchasing improves. So what are the various sources of financing? So we have got broadly public and private financing. When I talk about private financing here, I talk about all kinds of entities which are non-governmental in nature, okay? So public financing is usually from center or local government. It could be either spent by state or any parastatal enterprise of the government, and social insurance contributions, where services are paid off either by taxes or a compulsory health insurance contribution by either employers or employees, like the ESIC scheme, okay? So then the other mechanism is you have external donor funding. So both bilateral and multilateral aids that come from various organizations, and the ownership usually can be government, social insurance, NGO partners, and various other companies, okay? So when you look at the various financing options, one is the first thing what we talked about is what is the source from which the revenue can come in. One could be various partners that we talked about, and how are you going to finance? What are the options available? Either you can finance through a general revenue, or you can have insurance contribution, whether it is social, community, private. You can have a medical saving account separately. You can have out-of-pocket payers, or you can have external funding. So you need to understand that everywhere you have a mix of financing option, and you have to actually look at a trade-off. Everywhere there is a trade-off. So we cannot go beyond trading off. We should always remember that there are trade-off between equity and efficiency, horizontal equity and vertical equity, That is the decision that any financing activity in health really demands from a decision maker. So when you talk about financing, these are the stages through which a health financing function in any state actually moves through. That you pool your funds, you collect your funds, you purchase them, and then you provide for them. So in a general revenue, that is the traditional way, that it comes to a central pot and then through the revenue it is distributed to the various requirements for health needs, usually seen in low-income countries. Social insurance is more of a compulsory insurance, where premium and benefits are altered only through a formal political process. So this is a formal political process and not a whims and fancies of a political proclamation. Okay. So if you actually see the second option, that was the general revenue as first option, insurance is the second option. So in insurance, you'll have three kinds of subsidies that is possible. Either you can subsidize risk, low risk to high risk subsidy. So you can have a pool of both kinds of people with low risk diseases and high risk diseases like cancer. Or you can have a cross subsidy between rich and poor, so that you can subsidize the poor from the rich. Or you can have a cross subsidy between productive part of life and non-productive part of life. So as early as you can recruit people into the insurance scheme, the better is the functioning of the pool. The next option is the community-based financing. Typically, it believes in three principles, very clear. There has to be a community cooperation for such a mechanism. You have to have a self-reliance mechanism and a prepayment mechanism. Factors for success in the community financing is dependent upon the technical strength or institutional capacity of the local team, the financial control as a part of the broader strategy, because what happens is typically these funds get routed for personal financing. That should not happen. Third is the support received from outside organization and individuals and the diversity of funding. Usually community insurance, when they are linked with livelihood insurances, they work much better because the diversification happens. And then lastly is the direct out-of-pocket expense. These are the common health insurance mechanisms in vogue. ESIC has been one of the most successful model of co-payment between the state, the individual and the payers, that is the employers. And you have CGHS, which also has got a mechanism wherein the government funds for its employees and purchases services, tertiary care and secondary services from the private sector for its services. Okay. So how has health financing evolved? So if you look at low income country, you would see that the out-of-pocket payment, which is on yellow, is actually a larger component. The government budget funding is relatively lesser. And if you see, as you grow high income, the government budget and the national health services becomes a bigger chunk and the out-of-pocket payment actually goes down. Now look at some of these countries. We have seen Canada, Australia, Germany, Italy, Japan, UK, USA, Brazil, China and India. If you actually see, most of the countries spend close to about 9% of their GDP on health. And if you actually see, the out-of-pocket expenditure is much lower in these countries, closer to 13%, 20%, 21%. If you look at India, it is 62.4%. And their health performance, therefore, the life expectancy is therefore much better, close to 80 years. Now, these are the various government schemes which are there, of which two which are notable and have been sustainable and successful schemes have been ESIC and the Central Government Health System Scheme. Out of these two also, ESIC has been a very good social insurance scheme which has been able to sustain itself because of the co-payment mechanism, because of its ability to ensure that the risk pool is properly gate kept. So some of the countries where we evaluated their financing mechanisms, if you actually see the Medicare benefits and all these schemes, if you look at them, their financing mechanism essentially has a very strong, the government funding for essential health services. The complementary and supplementary health services are purchased by individuals through various insurance mechanisms, wherever it is, whether it is Italy, UK or Australia. Italy is slightly different in the sense that what they created was an Italian National Health Services. If you see UK, the NHS sits within the government, whereas if you actually see Italian National Health Services, it is at an arm's length. It is a society which has been created at an arm's length, watching over the activities of the government and ensuring that whatever funding that the government generates for health financing is actually routed equitably and efficiently. So this is a very unique model that Italy adopts. Germany also has similar model, which is called as statutory health insurance system. It's also a not-for-profit organization created by the government. Canada also has a universal health program, but it does not have a organization which operates the funds at an arm's length level. Andhra today has got similar model, wherein you have got a state health society which has been created to actually look at the insured funding mechanism from within the state. And believe me, the state has been able to provide 99% of health insurance coverage to all its population, irrespective of APL or BPL, which is a commendable achievement, and they have been able to do it for last 10 years. So it's a commendable achievement. Okay, it's not moving. I don't know. Can you please move this? Okay. So this is again Japan, Brazil. Brazil is financed through a general payroll taxes. China is not a model that I would like to discuss here. They have got different levels of insurance. Let's move. And all these, the hospital actually is paid either fee for service basis, or there is a global budget to a hospital to operate itself. And however, one thing is very common, that people, the essential health services, complementary health services and supplementary health services are clearly defined. Essential health services are taken by everybody from the government system, whether it is a rich or a poor. Everybody comes to the government system for taking the health services. You can imagine what ramification does it have. If you imagine every minister, every bureaucrat goes to all public hospitals today, believe me, all our public hospitals will improve. Right? But the point is, none of them reach to these public hospitals, excepting from some of the top-notch institutes like AIIMS or PGI or SDPGI. So primarily people go to the private sector. That is why private sector is going pretty well, and public sector is going to doldrums as far as efficiency is concerned. Next please. Next please. I think we'll have to change. I'm sorry. Yeah. So if you look at the sources of funding, I'll just finish another 2 minutes. If you look at sources of fundings, I looked at some of the South Asian countries. If you look at Maldives, public funding, go up please. Public funding is around 84%. Sri Lanka 46%, 50-50%. India 75% is out of pocket private funding. Okay. Nepal is also like that. Pakistan is also like that. Okay. Next please. Next please. Yeah. And if you look at fund channels in India, primarily out of pocket, Pakistan is similar, Bangladesh is similar, Afghanistan also 50-50%. Next please. If you actually, this is an important thing to understand, that how you evaluate a country. When the poorest quantile of a country or a state is able to get the subsidies, then you can imagine that your financing system is working well. If you actually see India, our poorest quantile is much below, and they are not getting the subsidy that is actually designated for them. Next please. So to summarize, if you look at the changing healthcare financing environment in India, there is a gradual reduction in proportion of release of funds to the states. The central government has decided that hereafter the states should take care of themselves. So that is reducing from 57% to 44%. The reduction in capital investments when it comes to technology, epidemiological shifts are there. Consumer is becoming more aware. This becomes more demanding situation for the states. There is an increased subsidy to employees. Continuing lower priority to preventive and promotive care. We have been always funding disease insurance. In true sense, we are not doing health insurance. Okay? Allocative inefficiencies in national health programs. So whichever secretary or whichever bureaucrat is able to put forth a case forward, our allocations actually shift in that direction, right? Say for example, the early 10 years, we had a mother and child problem. We significantly contributed to maternal and child health, but then we forgot about other health promotions that are required, which has to be delivered through the primary health care. So now also there was a challenge as far as India is concerned. The word primary health care, PHC word, is synonymously used for primary health care and primary health center. So the funding which used to come for primary health centers used to get routed to provision of primary health care in the community. So the primary health centers remained neglected. The secondary and tertiary health centers were equally neglected because the government felt that I am doing enough and more in the primary health center. If you remember the National Health Policy 1983 and later 2000s, right? So what you see today is the medical colleges have significantly lost on technological development, government medical colleges. So they had to grow the private medical colleges to provide for technological support, right? So now if you actually see the changing system in financing, those kind of decisions, how they impact our overall financing. So one financing decision, all of you would be remembering in early 90s, my faculty would remember, early 90s, there was a completely 20% slash of manpower across the cadres and across sectors. Health sector also suffered with that. Although health sector innovated with outsourcing mechanism and insourcing, this slashing of 20% of manpower from health sector actually impacted significantly the quality of care being provided in our public healthcare delivery system, right? So what is important when you see that not all good things are affordable in poor countries. There are real trade-offs to be decided. So you have to have a very social and equitable mindset, and health as a state subject should be understood seriously. Next, please. And if you see from the international experience, I could not spend much time on that. If you see, the three things are very important in here. As a regulator, you have to define the packages of services that the government will commit to provide very clearly. You will use private sector to drive excellence and efficiency and not to provide the essential services. Because the private sector at any given point of time would like to see a return on investment. So you should not expect them to provide essential services. You should expect them to provide efficiency and top-end services. Third-party monitoring is very important. We in health sector, unlike any other sector, we detest any kind of third-party monitoring. It is only when it is shoved down your throat that we do accreditation or grading or rating. So NABH, it is people are going ahead with it because you require it for CGHS and ESI empanelments. Otherwise, believe me, nobody would like to do an NABH, right? So why is that we have to be forced for a third-party monitoring? It's very important that a third party always monitoring should be there. Second is the implementation of models. The sources and methods of financing essential services like immunization is very important. And it should be cutting across population, across categories and age groups. How financing additionalities like wellness, that is supplementary and complementary insurance, can be provided. Overall funding, how you are going to do it at an arm's length, like some of the models that have been shown in Italy and Germany is a very good model to be looked at. And you actually manage your priorities within the healthcare delivery system by incentivizing people to do well, like pay for performance, fee for service. All of those can be used as a model for enhancing good performance. Government purely behaves as a regulator of setting up policy and giving directions to the provider. So if, say for example, if I as a government, I am behaving as a provider today, as a government institution, I should also be going and following all the rules of the land as regards the health sector is concerned. Next, please. So therefore, the key message are only three to carry from this. Health financing is a means to an end, and it has a demographic and epidemiological and economic situation which determines the need and the ability to meet them. We cannot have one size fit all. We as a country are heterogeneous population and therefore can actually understand this much better, how to give a mix of all these models and be sustainable. ESIC has been a very successful model which can be actually looked at a national level as well. And I remember 2010 also, ESIC was sitting on a coffer of 1700 crore profit, right? And government doesn't know what to do with that. So it is there sitting. So it is whose money? It's our money, okay? Strategies must be therefore adopted to local context, including fiscal space. Thank you very much.
Thank you, Madam Dr. Saman Nagarajan. As you know, India being the most privatized financing market in the world, and Dr. Saman Nagarajan has expertise in private financing as well as public financing. He has very deliberately explained all the financial resources, diversity of financing options, and public private financing compared with Indian scenario with the global scenario, and highlighted so many government schemes. It is really a very good insight to this financial management. Thank you, madam. And our next speaker is Dr. S. Ramesh Babu. I welcome for his deliberations.
Good afternoon, ladies and gentlemen. Warm welcome to all of you for this session. I've been in practice, particularly managing corporate sector hospitals, private hospitals, past 25 years. And based on my experience, I've given you certain guidelines for this. Now the first, I'm sorry. Going back. Okay, that's strategies for improving hospital revenue. So let me ask you a question. Whatever you do a business, whenever you do a business, what do you do it for? Why do you do a business? Pardon? Profitability, that's right. Profitability is the most important reason for doing any business. Service and all comes next. But profitability, and the next point is growth. You never want your hospital or organization to be static. You want it to grow. So these are the two reasons why anybody starts a business, particularly hospitals. So profitability and growth are not bad words. You have to do it, otherwise sustainability will become a problem. That is why this conference, safe and sustainable hospitals. So strategies for improving. I am Dr. Ramesh Babu, and I am the CEO of Srikamatchi Medical Center, which is, I have come from Thanjavur. This hospital is in Thanjavur. Now Thanjavur, you know, I am coming from a land of temples, from a city of temples to a city of temples here, Bhubaneswar. So from Thanjavur to Bhubaneswar, city of temples to city of temples. And this temple is one of the world UNESCO heritage site. Okay, the most important part of this hospital, this temple, is that the shadow of this temple never falls on the ground. Even at 12 o'clock, whatever time of the day, it never falls on the ground. This was built in 1010 AD. Okay, almost 1,000 years back, 1,000 years back it was built. But it is a marvelous to see. Whenever people come to Bhubaneswar, they see Jagannath temple, Lord Jagannath temple. Similarly, when you go to south, you have to see this temple just to see its architecture. One of the most brilliant architectures that have been done in the entire country. So that's, and look at that, that's one of the highest vimanas. And that is on the top of it, you have kumbam you call it as, and that is made of a single stone. You can't even imagine how they've lifted it up that height. And that was a strategy, okay, used in those days. Now the same strategy, we have to adopt it here. And that's our new hospital where I am working, Srikamatchi Medical Center, which is a 300-bed hospital, okay. Now, I am going to give you, on my practical experience, just 10 strategies for increasing your hospital revenue, which I've used in many hospitals, and definitely most of them have been quite successful in that. The first strategy is streamlined workflows. Very, very important, because most of us fail in this workflows. Everybody cannot do everything. Please understand that. Management, you should understand, everybody cannot do everything. So each person is designed to do certain work only. So you have to find out, as hospital administrators, as managers, we have to find out what is the potential in each person, develop that potential, and definitely it will be a great blessing to the organization. So you have to do a streamlined workflows. Your workflows has to be streamlined. Now, next point is, another thing is, in the streamlined workforce, you should never do a micromanagement. Don't do a micromanagement. Most of the hospitals I've seen, the top man always does a micromanagement on all things. It is not possible. Humanly, it is not possible. So never do a micromanagement. You have to allocate work and then oversee that. So this is about the number one. Number two is automation. Now, a lot of things are being done in automation. You have to invest in automation. No other go. Today, in this world, if you want to survive, in any organization for that matter, automation is a must, and even hospitals are not exemption to that. So if you do latest automation with latest things, definitely your organization will grow and it will become profitable. So automation is the key word to survive in this present century. Now the third one is revenue leakage. There will be a lot of revenue leakages in a hospital from small areas, and you have to plug them. It is your experience. It is how do you take care of all those things. Plugging revenue leakage is one of the most important things so that your profitability will increase. And if you leave it, it will become a continuous drain, and it will, your hospital will not survive. Okay. Number fourth is doctor-patient relationship. It has to be excellent. We all know that. Previously, doctor-patient relation 20 years back was very excellent, because everything they used to tell, it is like a family doctor concept. Today, it's not like that. Today, as soon as he go, he will write investigations, do all these things and come. So there is no personal relationship at all. Everything is dependent on machine. So you have to develop a successful organization, a profitable organization will definitely do this doctor-patient relationship so that the revenue is generated more. Next point, this is the doctor-patient relationship. Next point is, now a lot of things are being spoken about patient safety, because that is the thing that every hospital is trying to do, and the world is celebrating the Patient Safety Day every year with new themes and all. So patient safety has become, which was never heard about 5-6 years back. Today everybody is talking about that, and you have to invest on patient safety, because that is where you will get more patients. Patients will become loyal, and they will become again and again. Now, next point is quality. Invest in quality. Quality, again, 20 years back, nobody said, if we say quality to your hospital, particularly to a doctor, he said, what quality and all? I don't believe in all this quality. I believe in my quality, they used to say. Now, today it is not that. Today, everything is evidence-based. Evidence-based medicine. Today, we're talking about morning, we saw some session evidence-based design. Everything is evidence-based. You have to prove that this has already been done and proven. So, evidence-based medicine. So, quality, you have to inculcate quality with every staff of the hospital, including the doctors. That is most important, because most of the hospitals fail because doctors don't immediately embrace that sort of quality. So they will take time. So you have to keep on doing that to make the doctors understand the importance of quality. That's okay. Next is training and development. Invest on training and development. Every organization has to do a training development, and you have to, the management has to see to it that you invest a lot of money on training and development, because that will bring lot of returns to your organization. Because every hospital, if you take a new hospital, all are new, every system is new, they don't know what is happening, everybody has confusion, chaos and all. If you put a proper training and development system, definitely that will improve. Now, the next is employee welfare. This is where most of the hospitals fail, because they think, I am an employer, you are an employee. You have to do whatever I say. No, all those days are gone. Today, you have to invest on employees, employee welfare. How do you retain your employees is an art. You have to practice that. Okay, how long you will retain? See, Tatas, they say, one of the best employers in the country, in the world. They say, because they know the trick of retaining an employee. That is why even when the Bombay problem happened, all these people went and saved the people who are staying there. This is how, that is just come. But even in a normal hospital, if there is a fire, the employee only runs first. Okay, and starts seeing other, so they don't bother. This is what I'm telling, because the employer doesn't take care of the employee. So whenever a critical situation comes, they just dump the employer and leave the organization and leave anything. They will not help. So invest on employees. That is one of the most, do a lot of welfare measures, do a training program, meet them every month at least, and do all such activities, they will be loyal. That includes doctors also. Even if you don't talk to a doctor for a long time, he says the management is disappeared or what, he will ask. So you have to do that. Employees' welfare is very, very important. Now next comes the revenue areas. See, there are certain areas which have to concentrate on the hospital. Look at that. First one is laboratory. The second one is pharmacy. And third one is food and beverages. These are the three areas where there is lot of profitability, profit is there. So you have to concentrate on those areas, because small things will lead to a leak, and then you will find one day everything is running at a loss. I worked in this hospital, Bhubaneswar. I was the MD of Kalinga Hospital, and I was also the CEO of Apollo Hospital, Bhubaneswar, after 10 years gap. So I know where are the leaks happening, where all these things you have plugged. And particularly when you take care of these three areas, definitely your profitability is quite high. Even the wards, the outpatients will not give you the money that these three areas will go. So concentrate on these areas, and definitely your revenue will increase like anything. And finally, I want to say leadership. That is one of the most important things of any organization, to sustain, to be safe, to make profits. So everything depends on your leadership. So leadership, without leadership, nothing is going to happen. So when I initially talked about profitability and growth, this profitability and growth are brought in by the loyal employees. The loyal employees, how do they become loyal employees? The satisfied employee becomes loyal. Now, how do you make an employee, the patient, customer satisfied? By giving him value for money. Who gives you value for money? Your employees, not your ordinary employees, but your loyal employees. And how do you make your employees loyal? By satisfying them. So a satisfied employee becomes a loyal employee. And how do you make a satisfied employee? By putting systems. So, and who puts the systems finally? That's the leader. Not every manager, not every CEO, not every managing director. That's the leader who puts the systems that makes the patients that makes the employees satisfied. Employees become loyal. Employees giving value for money for the customers. The customers are satisfied. Customers become loyal. Then there is profitability. Then there is growth. So this is the basics of anything. So leadership is certainly the most important factor in any organization to sustain and make profitable. Thank you very much for that.